Hello everyone, welcome to our next YouTube live session, that is must do SBA'S for MRCOG part 1. Yes, as the exam is fast approaching, it's just around 1 month and few days for the exam. So we have to focus more on the questions. And as we solve the questions, what we do is actually we can remember our facts, and also we can just prepare ourselves for the marathon. That is the 200 questions in a row which we have to solve in the exams. So we need to practice for that. As for any marathon, what do we do when we practice for the race? We start with a certain amount of distance, running for a certain amount of distance, and then we keep on increasing and decreasing, right? So that's what is for the exam as well, right? If you have that stamina of attempting the 200 questions, you have done half of your job. So the way how you can do that is you can just keep on practicing 30 questions in a day, increase it to 40, go back to 50, and finally before the exam day, you should be 100 questions in a day. So that's a very important trick here for your last minute preparations before you go for your January exam. So let's start today's session. This is must do, and these are from the recent recalls. Yes, very recent recalls. And I could just promise you that at least 2 to 3 questions will be there in your exam paper from these 15 questions which we are going to solve today. Yes, it's a very good bit, right? So you are lucky to be here with us today, and let's start. Must do SBA'S MRCOG Part 1 exam from the recent recalls. So here we go. Would love to hear from you in your live chat. And definitely, it's a very good thing if you can keep on answering. That would be a very good revision for you. And of course, we are going to discuss about the explanations as well. It's not just about mugging the answers, because many a time the questions are not exactly the same in the exams, but the concepts are repeated, right? So this time, if they have asked about the upper vagina, maybe next time they'll ask about the lower vagina, right? So that keeps on changing. So if we have built a concept around that particular point, then it becomes very easy and you are well prepared in 70% less study time, which is a tagline of MRCOG courses. So if you really want to prepare in 70% less study time, then you are welcome to join us. So you can see the glimpse of that in today's session. So let's start with the SBA 1. And definitely I'm looking forward to hear your responses in the live chat. The upper part of vagina receives its blood supply. Let me go slow, right? You will be answering. So upper part of the vagina receives its blood supply primarily from which of the following arteries? The question is about the blood supply of upper part of vagina. So yes, there are options: uterine and the ovarian arteries, vaginal and the pudendal arteries, middle rectal and vaginal arteries, pudendal and inferior gluteal arteries, ovarian and inferior rectal arteries. What comes to your mind as a first option? Definitely looking at vagina, we think about the vaginal artery, right? So if I look at the vaginal artery, what are the two options available here? The B option is vaginal and the pudendal arteries. Does it goes well? Pudendal is going to supply the upper part of vagina? No. So B1 although seems very tempting because vaginal is there, but pudendal is not correct. So this is not the best answer. Coming to the C option, middle rectal and the vaginal arteries. Again, a tempting one, looking at the vaginal as an option. But is the middle rectal right option? No, middle rectal does not come here in the vagina. So although the B and C options have the vaginal in it, but that's not the correct answer. Then what is the correct answer? So it's the uterine and the ovarian arteries. Sounds bit fishy, but vaginal artery can many a times not a direct branch from the anterior division of interiliac artery. It can arise from the uterine artery as well. So uterine and the ovarian arteries is the best answer which is available here. Right? So A option is the correct answer. So you can remember in the mnemonic, I promised you that you will remember all this definitely by the time you leave the session. All 15 questions will be on your tips. So let's learn with the mnemonics. Again, decreasing our study time to remember the things again and again. So mnemonic to remember, upper vagina is supplied by U and O, so uterine and the ovarian arteries is the correct answer. The upper part of vagina receives its blood supply mainly from the vaginal artery, which may be a branch of the uterine artery, and there is a small tributaries from the ovarian arteries which make the anastomosis there. These arteries are branches of internal iliac artery, and in contrast, the lower part of the vagina is supplied by the vaginal and the pudendal arteries, right? So the pudendal artery is in the lower part. Again, remember, you have to pick up the single best answer. It is not about choosing a single correct answer, right? It is a SBA, not SCA. So always remember, we have to pick up the single best answer. So that's it. Now coming to SBA2, the perianal area receives its sensory nerve supply primarily from which of the following nerves? Perianal area receives its nerve supply primarily from which of the following areas? So which is the nerve which is the somatic nerve to this particular area? It's the pudendal nerve, inferior rectal nerve, superior gluteal nerve, posterior femoral cutaneous nerve, and ilioinguinal nerve. Which one is going to come here? Yes, pudendal nerve is the correct answer here. So, inferior rectal nerve is the correct answer here because that's going to supply the perianal area. Actually, the question is not about the perineal. That's the confusion here, right? So take it right. The message should be it's not perineal. It is perianal, right? If the question is about perineal area, then definitely pudendal is going to be right? But if it is about perianal, that is the area around the anal ring, then it's going to be inferior rectal nerve. So you can see a small difference in the word can make a difference in your answer. So it is very important. What's the clear message here? It's very important that we need to read the question very carefully, and each and every word is very, very important. If you just go by, oh, perineal, oh my God, it's going to be pudendal, and then you are going to lose marks there, right? So perianal is inferior rectal nerve. Inferior rectal nerve for the rear portal. Inferior rectal supplies the rear or the perianal area. Think of a portal as the sensitive opening area that needs specific innervation. Definitely inferior rectal nerve is the branch of pudendal nerve. So inferior rectal nerve is a branch of pudendal nerve and provides the sensory innervation to the perianal skin and external sphincter. The pudendal nerve itself originates from the sacral plexus S2 to S4. This root value of pudendal nerve is itself an exam question. So we have actually talked about 3-4 questions here. Rather, in this one single question, we have talked about 4 important questions. One, the nerve supplying the perianal area is the inferior rectal nerve. The nerve supplying the perineal area is the pudendal nerve. The third question is, what is the root value of the pudendal nerve? So that is S2 to S4. And what is the motor nerve to the external anal sphincter? Is itself a very important exam question. So that is inferior rectal nerve. So we have dealt with 4 questions in this one question. Isn't it reducing your study time by 70%? So SBA 3. Let's go by SBA 3. During an appendicectomy, what is appendicectomy? The removal of the appendix, the surgery. Which artery is most likely to be injured? Which artery is most likely to be injured when you are doing the appendicectomy? So think about something which is going towards the right iliac fossa, because we know that the appendix is in the right iliac fossa. So any vessel which is going towards that is going to get injured while we give the incision. So what are the options here? Deep circumflex iliac artery, superior epigastric artery, inferior mesenteric artery, femoral artery, and obturator artery. Which vessel makes sense? If you can just remember which vessel is going towards the right iliac fossa, that's going to be the correct answer. Yes. Keep answering in the live chat. Yes, very good. Right. That's it. So it's the deep circumflex iliac artery, right? You can remember with the mnemonic, deep cut during appendicectomy. So deep circumflex iliac artery cut relates to the surgical incision in the lower right quadrant near the iliac region. So finally, it is deep circumflex iliac artery, and you can remember the deep cut needs to be made for the appendicectomy. So deep can help you in remembering the answer. Deep circumflex iliac artery runs along the inguinal ligament and is close to the surgical site of appendicectomy. It can be injured during procedures involving the lower abdominal wall, particularly the right side. This artery is a branch of external iliac artery supplying the blood to the lower abdominal wall and the iliac region. Coming to the SBA4. The embryological origin of the trigone of bladder is derived from which of the following structures? The embryological origin of the trigone of bladder is derived from which of the following structures? Yes. Is it a mesonephric? Is it a ureteric bud, cloaca, allantois, or it is from the endoderm of the urogenital sinus? So if you think about the embryology of the bladder, I think what comes to your mind is the endoderm of the urogenital sinus, because that gets divided into two. Anterior part forms the bladder and the posterior part, that's the cloaca, forms the anal canal. So are you still thinking about answering as an endoderm of the urogenital sinus? Yes, no, okay. So there is an exception, and RCOG loves exceptions, right? So whenever there are exceptions, RCOG loves to ask those questions and they carry the marks, and you have to remember the exceptions. So trigone of the bladder is an exception of being a bladder being endodermal in origin, right? So what is happening to trigone? That is derived from the lower ends of the mesonephric duct. So the trigone is an exception and it is derived from the mesonephric duct. And as I told you, the RCOG loves asking the exception. So wherever something is in the exception, which is not in tune with the general rule, RCOG is going to tap that point and ask you for the exam, and that becomes a very important exam point, right? So same is happening here. So the key message is that you have to remember the trigone of the bladder develops from the mesonephric duct. The rest of the bladder originates from the endoderm of the urogenital sinus. The trigone remains distinct due to its mesodermal origin, unlike the rest of the bladder, which is endodermal in origin. Yes, absolutely. You have to remember this point. Very, very important point. Again, we have covered two questions in this particular question. One is, what is the origin of bladder in general? So that is the endoderm. And the origin of the trigone is the mesonephric duct. So that is the mesoderm. So we have learned two questions here. So although we have just covered 5 questions, but we have actually covered multiple questions. A cyst on the lateral vaginal wall, such as Gartner's cyst, is a remnant of which embryological structure? Again, the remnants of the embryological structures and their origins is a very, very favorite topic for MRCOG Part 1 exam. So we need to remember about the paraophron, epophron, Gartner's duct cyst. These all are very, very, very important one, and you need to remember what is the embryological origin of this remnants, right? One question you can definitely expect from the embryological remnants. So if we'll think about the Gartner's duct cyst, you can feel this cyst in the in the lateral part or lateral vaginal wall, right? So from where does this come from, right? So is it a mesonephric duct? Is it a paramesonephric duct? Is it a urogenital sinus, cloaca, or allantois? What it is actually? So yes, what do you say? Waiting for your answers in the live chat. Yes, keep going active. So it is mesonephric duct, right? It is a mesonephric duct which leads to formation of this. So usually the mesonephric ducts, they are more active in the male reproductive system. In female reproductive system, actually it regresses, right? So normally the mesonephric duct regresses in the females as it primarily contributes to male reproductive system. But the catenous cysts, they arise as the embryological remnants of the mesonephric ducts, that is the Wolffian ducts. These remnants can persist in, in the lateral vaginal wall or the broad ligament, right? So these remnants can persist in the lateral vaginal wall or the broad ligament. So that's the mesonephric duct remnant. Again, we have covered one exam question. So next, coming to the SBA 6. Which of the following forms the protective outer layer of the Graafian follicle? Which of the following name represents the protective outer layer of the Graafian follicle? Is it theca interna, theca externa, zona pellucida, granulosa cells, and corona radiata? Theca interna, theca externa, zona pellucida, granulosa cells, and corona radiata. Which one is this, right? So the protective outer layer of the Graafian follicle is theca externa, right? So that is theca externa. Because see, from as the name indicates, it is externa. So it forms the external shield. So it forms the external shield. And this refers to layers surrounding the follicle, right? So this refers to the layers surrounding the follicle, and externa is thin external shield as it forms the outermost protective layer. Now, theca externa is the fibrous outer layer of the Graafian follicle and provides the structural support and the protection. Beneath it lies the theca interna, which is involved in the hormone production, that is the androgens, and other layers like the granulosa cells and zona pellucida are more directly involved in nurturing and protecting the oocyte, but are internal to the theca externa. Other layers like the granulosa cells and the zona pellucida are more directly involved in nurturing and protecting the oocyte, but they are internal to the theca externa, right? So the theca externa is the correct answer. SBA 7. Which of the following structures passes through the Alcock's canal? Which of the following structures passes through Alcock's canal? Now, in this case, there is a trick, because if you do not know what is meant by the Alcock's canal, then you can go wrong. Because if I ask you a direct question, which of the following structures pass through the pudendal canal? It's very easy. We know that the pudendal canal will have a pudendal nerve and pudendal vessels. But when I ask you about the Alcock's canal, here comes the trick. Now you need to know what is Alcock's canal. What is, this is the other name of which canal actually, right? So if you know that this is other name of the pudendal canal, then your question is quite simple and very direct from your thought, right? But otherwise, you may keep on thinking like, what is Alcock's canal? So it's very important, wherever there is a specific name to any structure, right? It is very important that you know that name. Again, RCOG loves asking you such things which you are bound to make the mistakes, okay? So Alcock's canal is another important point here. So which of the following structure passes through the Alcock's canal? And of course, it is the pudendal canal. So the answer becomes very, very easy. Is it pudendal nerve? Is it femoral nerve, sciatic, obturator, or ilioinguinal? So certainly it's going to be pudendal nerve, right? As the name indicates for the pudendal canal, it's going to be the pudendal nerve. So Alcock's canal, also known as the pudendal canal, is a fascial tunnel within the obturator fascia. It contains the pudendal nerve along with the internal pudendal artery and vein and provides the sensory and motor innervation to perineum. The other options do not traverse the Alcock's canal and are unrelated to its anatomy. So it's just a trick. If you know the Alcock's canal is another name of pudendal canal, the question is just direct for you, itself speaking about the answer, right? But we need to know these specific names. Coming to the SBA 8. Which of the following nerves is located medial to the anterior superior iliac spine? Which of the following nerves is located medial to the anterior superior iliac spine? Very important nerve, which is often asked for its injury as well. And let me give you the clue. The injury to this nerve is basically leads to only the sensory deficit, and there is no motor deficit, as this particular nerve, which we are going to talk about here, does not supply any muscle. It does not supply any muscle. It only has the sensory supply for the skin, and that is the anterior and the lateral part of the thigh. Now I think you know the answer very well. So yes, it is the lateral cutaneous nerve of the thigh, right? So this is lateral cutaneous nerve of thigh. This is a very, very favorite nerve of RCOG, right? They keep on asking questions about it. So what are the points we need to remember for this particular nerve? So first thing is lateral femoral cuts close to anterior superior iliac spine. Lateral refers to the lateral femoral cutaneous nerve. Cuts, the nerve runs along the lateral side of the pelvis in the thigh, and the nerve passes medial to anterior superior iliac spine. The lateral femoral cutaneous nerve of thigh is located medial to the anterior superior iliac spine and is responsible for providing sensory innervation to the skin over the anterior and lateral aspects of the thigh. So it provides only the sensory innervation to the skin over anterior and lateral aspects of thigh. Other nerves like the femoral, obturator, and the sciatic are located in different regions of pelvis or the lower limb. The ilioinguinal nerve is also in the region but does not pass directly medial to the anterior superior iliac spine in the same way. Right? So this is the explanation for this particular nerve. And remember, this point is very important that it does not have any muscle supply. So whenever this nerve gets injured, then there is no motor loss. Only the sensory loss is there. Then we call it as meralgia paresthetica. Another important name for the condition, meralgia paresthetica. Now coming to SBA 9. Which immunoglobulin increases in cervix during term pregnancy? Which immunoglobulin increases in the cervix during term pregnancy? Right? A tricky question, right? We need to think about what increases in the cervix during term pregnancy. So whenever we have to protect the mucosal barriers, what we are actually required, the antibodies in the mucosal barrier, right? Now I think you have the answer. The antibodies which are related to mucosal barriers, is it IgM? No. Is it IgG? No. IgA? Yes, that's what prevents the mucosal barriers, right? So protects the mucosal barriers. So IgA is the correct answer. E and D, no, right? So A is the correct answer. Answer C. A for the antibody, A for acidic cervix. So A for antibody refers to IgA, which is an antibody, and A for acidic cervix. So IgA helps maintain a protective acidic environment in the cervix. So that's why it plays a very important role. So IgA is the predominant immunoglobulin in mucosal surfaces, including the cervix during pregnancy. It plays a key role in immune defense by protecting against infections and maintaining the acidic environment, which is important for preventing microbial invasion at the cervix. It plays a key role in the immune defense. We know that wherever the respiratory tract or other barriers, GI tract, whenever we need a barrier at the mucosal point, IgA is the most important one. IgG, IgM, IgE, and IgD do not significantly increase in the cervix during pregnancy as IgA does. Yes, coming to SBA10. The most common cause of female urethral caruncle is. The most common cause of female urethral caruncle is, right? So, what it is and in what age group it is common. In what age group the urethral caruncle is common. If we know that, then we know that what is the cause. It is common in the postmenopausal women, right? So it is common in the postmenopausal women. So basically, it is about the hypoestrogen. What happens in the postmenopause? The estrogen decreases, right? The collagen decreases. The tissue is not properly structured or not properly supported, right? So that leads to formation of the caruncle, which is a pinkish colored mass near the urethra, and it is the cause is the hypoestrogenism. So caruncle comes from low estrogen. Caruncle refers to the urethral caruncle and comes from the low estrogen. Hypoestrogen leads to the atrophic changes in the urethra, making the tissue more prone to develop a caruncle. Yes, perfect, right answer. So hypoestrogenism leads to thinning and atrophy of the urethral mucosa in postmenopausal women, increasing the risk of urethral caruncles. These caruncles are typically benign, and the condition is often seen in postmenopausal women or those with the low estrogen levels. Other options such as chronic urinary tract infection and diabetes can cause symptoms, but hypoestrogenism is the most common cause of urethral caruncle formation, right? So this is very, very correct, right? So urethral caruncle is very important thing. Another important question about the urethral caruncle is which age group, right? So it is common in the postmenopausal women. They can sometimes give you a postmenopausal with a pink colored cystic structure near the urethra, what it is, and then the answer will be urethral caruncle. So the questions can be vice versa. It can be either asked either way. Either they give you the postmenopausal women with a structure on the urethra and ask you about the caruncle, or they give you like caruncle is present in which age group, which is postmenopausal. And the third question here comes is the low estrogen levels, right? So again, 3-4 questions from this particular point here. Okay, now this is a question about your data interpretation and clinical management, a very, very important subject for your paper 2. Most of the paper 2 questions are from the clinical management and data interpretation. And remember, we all are practicing. It is very easy to decipher the investigations and come to the point and decide the management. We do that on our day-to-day basis. But what is important in the exam? What makes us fail in this too when we are actually practicing is this in our daily life? Because the practices we have to answer in the exam are as per the RCOG guidelines, as per the RCOG sources like GTGs, NICE. So if you are not well versed with those management options, then it's going to become very difficult, right? Then with your practice things, it may not be the correct thing, right? So we have to be very cautious about that we know the interpretation of investigations and the management from the RCOG sources. A 28-year-old woman at 27 weeks of pregnancy presents with the severe right epigastric pain, headache, blurry vision, blood pressure is 160/90, and proteinuria is +++. Her platelet count, ALT and AST are normal. What is the most likely diagnosis? So the woman has the 27 weeks of pregnancy and she has a right epigastric pain. There is headache, there is blurring of vision, and the blood pressure is 160/90. Proteinuria is 3 plus. So platelet count is, and the ALT, AST, liver enzymes are still normal. What is the most likely diagnosis? Can it be gestational hypertension, chronic hypertension, preeclampsia, HELLP syndrome, and acute fatty liver of the pregnancy? So what it could be? Gestational hypertension, chronic hypertension, preeclampsia, HELLP syndrome, and acute fatty liver of pregnancy. What it can be? Yeah, looking for your answers. Yes. Is it C or D? I can see the two answers in the chat box. C or D. Is it preeclampsia or is it HELLP syndrome? So it is preeclampsia. We can't say it is HELLP syndrome because HELLP syndrome means the low platelets and the altered liver enzymes, which are not here, right? Liver enzymes and the platelets are normal. So it is a preeclampsia. What makes it preeclampsia? So here it is 3 P's, which makes it preeclampsia. 3 P's: protein in urine, blood pressure rise, and epigastric pain. So protein in the urine, pressure rise, and epigastric pain. Preeclampsia, the key components are proteinuria, high blood pressure, and epigastric pain. The right upper quadrant pain commonly associated with the liver involvement. So basically epigastric pain, there is also could be right upper quadrant pain commonly associated with the liver involvement. Pressure is high blood pressure, that is 160/90, and the pain, which is severe epigastric pain, which is often a sign of liver involvement, right? So this is about the preeclampsia. So preeclampsia is characterized by high blood pressure, proteinuria, typically 1 plus or more. This is also very important, right? It should be 1 plus or more. Traces is not considered as preeclampsia and can present with the symptoms like headache, blurry vision, and epigastric pain due to liver involvement. The normal ALT and the AST suggest that liver function is not significantly impaired, and the normal platelet count helps rule out the HELLP syndrome, where low platelets are typically seen. Gestational hypertension can cause high BP but does not have significant proteinuria or symptoms like epigastric pain. Chronic hypertension does not present with the sudden onset of symptoms such as proteinuria and epigastric pain. HELLP syndrome and ALP, that is acute fatty liver of the pregnancy, should typically show elevated ALT and AST and often have more severe complications like low platelets. The mechanism of action of the progestin-only pill includes which of the following? The mechanism of the action of the progestin-only pill includes which of the following, right? So, now very important thing in this, it is asked in general about the POPs, right? So, we have to be very cautious about answering this question. We know that there are two types of POPs. One is the traditional pills and the other is the newer pills like the desogestrone. So when they haven't given you specifically whether they are asking about the newer pills, then we have to take the POP as a traditional pills, right? And when we take the traditional pills, then what is the mechanism of action of traditional pills? Endometrial desitoalization, inhibition of ovulation, blocking of implantation, suppression of FSH and LH secretion, or thickening of cervical mucus. It should be mucus, right? So thickening of the cervical mucus. What should be the correct? Yes. What should be the correct here? There are two main options which can be confusing to you, like thickening of cervical mucus and inhibition of ovulation, right? Which is going to be correct? So thickening of the cervical mucus, right? Thickening of the cervical mucus is the correct option for the traditional progesterone-only pills. If we talk about the newer pills, then it is the desogestrone. And when we talk about the desogestrone, it is inhibition of ovulation. Okay? So traditional pills is thickening of cervical mucus and the The newer pills have the inhibition of ovulation. So this is how we have to classify these two, right? So here, because it is not specifically mentioned, we will take it as the traditional pills, and that is with the thickening of the cervical mucus. So it primarily works by thickening of the cervical mucus, which acts as a barrier to the sperm penetration, making it difficult for sperm to reach and fertilize the egg, right? So it becomes thickened. Here we go with the next question, that is SBA 13. A 27-year-old female has been experiencing heavy menstrual bleeding. Again, heavy menstrual bleeding, important topic, but let's see what this question has to say. A 27-year-old female is experiencing a heavy menstrual bleeding for the past 2 years and was treated for mefenamic acid for 2 months. Now she is no longer complaining of heavy menstrual cycles. For the last 2 cycles, she had just a spotting in that, and her prolactin is elevated to 1200 and her beta HCG is 7500. What is the most likely diagnosis? Do you think this is hyperprolactinemia, or it is something related to fibroids because she had heavy menstrual bleeding, or it is prolactinoma? What it is? Beta HCG is high, right? So it's pointing towards something, that is pregnancy. In pregnancy, estrogen, beta HCG, estradiol, prolactin, everything is going to be high. So this is a very, very favorite scenario of RCOG, many times repeated in the recalls. So because basically they sometimes give you the high estrogens with high prolactin, sometimes they give you with the high beta HCG with high prolactin. So in that case, they will definitely give you the option of hyperprolactinemia and the prolactinema. So please don't go with that. And the heavy menstrual bleeding here is basically just giving you a pointer that there is a change in her pattern of menstrual cycle, right? Previously, it was heavy, but now it has become scanty. So, while she is not having amenorrhea, still we are going with the pregnancy. We all know that till 3 months, patient can have spotting on the day of the period in the first 3 months of pregnancy as well. So, this goes in tune with that. So, B is the correct answer. Sorry. Iodine accumulation in the thyroid cells involves the symport with which of the following ions? Is it calcium? Is it potassium, chloride, sodium, or magnesium? Which one is the correct answer? Yes, let me wait for your answers as well. Yes, so it is sodium symport, right? So sodium symports iodine to the thyroid. Sodium refers to this refers to sodium, which plays a key role in the iodine transport. Sorry. The transport of the iodine into the thyroid cells occurs via a symporter, which works by coupling the movement of iodine with the sodium ions. So it's the sodium iodine symporter. Again, an easy question you can easily score in your exams and repeatedly asked, right? You will find this question in 80% of the papers. So again, it's a very, very important one. And this is the final question with which we will end our session. So they are the picture questions, right? Picture questions are very important. You may have 15, 20 picture questions in your exam. So it is very important that you know about the picture questions. So you have to identify this ultrasound image. Identify this image. What does this say? Yes. Is it a follicular cyst? Is it ectopic pregnancy? Is it is a cystadenoma, or it is an endometrioma? So what does it shows? It shows a ground glass appearance. You can see throughout the picture there is a similar uniform appearance. So this is a ground glass appearance, and ground glass appearance is seen in which type of ovarian lesions? So it is seen in endometrioma. Yes, very rightly mentioned in the live chat. So happy to hear the right answer. Yes, it is endometrioma. So that finishes the today's session, and go confidently in the direction of your dreams, and you will certainly be able to achieve what you want to achieve. And if you want to study only what comes in exam and reduce your study time by 70%, then you are welcome to MRCOG courses. Bye bye. Thank you so much for joining today, and we'll see you again in the next live session.